Hey everybody, welcome back to another weekend episode of Dentistry Unmasked. My name is David Rice here, as always, with
Hey everybody, Pam Maragliano-Muniz. David, I'm so excited for this topic because I feel like it's one we have to talk about, but also I think it's one that kind of scares people.
Scary and I must talk about. Let's do it. We have a great guest today.
We do. Dr. Richard Marn, welcome, dental anesthesiologist.
Thank you. Thanks for having me. Actually, I'm not a dentist. I'm actually a physician. So, um, I guess my clinical work would be technically a pediatric anesthesiologist.
Ah,
Yeah.
Ooh,
But
awesome. So tell us,
I'm married to a pediatric dentist.
how does this work? So, what's your day-to-day workflow? Do you work in ORs with pediatric dentists? Are you, part of a hospital, or do you go into private dental offices?
Great question. Clinically, I am only in private offices. Um, I used to work in Mount Sinai Hospital, and we used to do these full mouth rehab cases on kids. I did that for a number of years. And then since 2016, I've been doing office-based dental sedations, especially for kids. About 80+% of my cases that I do is all pediatric sedations. Um, and so, yes, I'm basically clinically a mobile sedation service designed specifically for dental and oral surgery practices.
I love this so much because, can I just say it? People cowboy up in our industry way too much and take a weekend warrior course and think they can just be delivering anesthesia. And I feel like this is so much of a better
Mm.
way. So I might ruffle a couple feathers, but
That it might, but sometimes you have to do that to break the status quo, to make sure that your patients and your practice and your investment in your career survives and perseveres and has legacy. You have to do something different than what the rest of industry does. And so if we need to ruffle little feathers, well, maybe that might be might be necessary.
So let's talk about that. Let's talk about the difference between a course that, say, David and I could take if we wanted to offer sedations by ourselves in our practice versus what you have done and what's different about you coming into a practice versus us trying to maintain things as just part of our own workflows.
Got it. So I think you're trying to ask is comparing an anesthesiologist coming into a practice and providing sedation versus the dentist doing their own training for themselves and then providing their own sedation, right? Is that okay?
yep.
So um, let's start with what I do. That's easy for me to understand. I do that every day. So for someone like me, um, uh, as a physician, I come in and basically provide sedation services for that dental practice. Obviously, I meet with potential clients first, and we have a little office interview, and they get to meet me. I get to meet them, make sure we're a good fit, and make sure they have the appropriate items that they need for sedation. I have a checklist that I make sure that they have necessary things, but 99% of what is necessary I would bring. Okay. And so that's the general setup. And the benefit of having an anesthesiologist come in is that it kind of helps take the mind off the dentist to have to worry about doing two things versus one. Um, and obviously, there's a benefit of just doing dentistry and focusing just on dentistry and just really making that stellar versus trying to manage that plus sedation that you're trying to do on your own. Now, the other side is, of course, you want to do sedation on your own. We see this all the time, right? We got general dentists that are doing these weekend courses, like you mentioned. We have oral surgeons that are doing their own sedation as well. We have some pediatric dentists that may do some oral sedation as well in their offices. So there is a population that's unclear how big that population is, or niche, I should say, of dentists who do their own sedation. Um, I I feel that, that definitely there's a market for doing some. Obviously, there's a benefit. There's obviously some revenue and income benefits of doing your own sedation because now you can charge for both the dentistry and the sedation, obviously, and not having to worry about a third party coming in. But of course, the drawbacks is really ultimately is that team without an anesthesiologist really prepared for an emergency, right? So everything's great. Day in, day out, you do a little sedation, you do a little Versed, a little light nitrous, and you're doing sedation on your own. Hey, a case does great. The patient pays you. You get a little bit of insurance money. It's fantastic. The question is are you really prepared for that emergency? Because that's not no matter how much money you make, that one emergency, if you do not know how to manage it well, in my opinion, will not only, of course, hurt the patient, but it could devastate your reputation, it just devastates your team morale, devastates, of course, the income and potentially bad publicity that comes with that. And I think people, just in general, they think, well, it'll never happen to me. That's that's a misconception a lot of people have. And there's a lot of close calls that people have. But the fact is, sedation emergencies are a real thing. We have a lot of situations where people get hurt and, of course, have bad outcomes. So I think it's a matter of, if I do sedation in my office, can my team handle those situations where a bad outcome could happen? That's really what in my mind, that's what it comes down to. It's not the medications. It's not making sure you have the latest laryngoscope or intubation technique. It's not whether you necessarily even vet the patients out, because even when you vet patients out correctly, emergencies can still happen. So really it comes down to, in my mind, you can do sedation in your office with or without me. That doesn't really matter. That, to me, that is an important point, but not the main point. The question is, can you manage that emergency when it comes down?
Mm-hmm.
I say that all the time. You shouldn't, like, regardless of the procedure. Like, I'm like, even if it's placing implants or, Botox, I mean, you really should be prepared to handle any adverse event that can take place. Or otherwise, we probably shouldn't do it. You can't always just kind of hope you knock it out of the park every time. So, what are kind of common mistakes that dentists are making when they're sedating patients that could put them at risk for a negative outcome?
Great question. So I think there's some misconceptions. I think we can lead with that. One is that there's like 4 misconceptions that people typically have. Number one is they think it won't happen to them, right? I mean, typically you give, for most sedation cases, it's a very positive experience. Patients love it, dentists love it, the staff loves it. It's usually a very positive experience. So, if that keeps happening and nothing really bad happens, like the conception that nothing will happen remains out there. And so that's a misconception. It won't happen to me. The funny thing about emergencies is, by definition, you can't predict it. And so to think it can't happen to you is it's very misleading. Number 2, that 911 will come in time. And so actually, I'm not sure about other cities, but in New York, I mean, I'm curious, do you guys happen to know, by the way, what your response time on average is for a 911 if you were ever called to your office? Just curious.
Mine is actually really quick. The fire department, you could like throw a football. Like, if you have a really good arm, you could throw a football and hit them. Like, I couldn't, but like somebody else, David could.
All right. But what you can do is you can find out what your average response time is in your city. And so in New York, the average response time to an emergency in 2024 is 9.5 minutes. That's average. Now, if you have someone having a very bad situation, like getting hypoxic or anaphylaxis, that seems like a long time. And that's, by the way, after you call them. That doesn't include the time where you're deciding whether to call them or not. Calling 911, that is. I read somewhere a few years ago that in Atlanta, Georgia, that average time is 30 minutes.
Ooh. What?
Yes.
Wow.
Yeah. This is from an article I read. Now, that's why it's very important to understand what your resources are, should you need their help, right? So 911 is going to show up on time. Number 3, that my team won't panic. There's this assumption that when something happens, that we'll know what to do. We're doctors, or we're a very professional team, And the fact is, I have talked with many an oral surgeon and dentist, and they have a lot of concerns that of their own innate ability to perform under duress. There's a quote I used from one of my mentors I used to have a couple years ago, and it's very relevant. It's not really relevant. He was using it from a business standpoint, negotiation standpoint. For me, it's relevant even in our business. And the quote he uses is, when emotions go up, intelligence goes down.
Mm.
And I find that not only just relevant in this professional medical emergency situation, but even in my personal life. Like when I'm maybe not having the best conversation with my wife, my emotions go up. I probably don't say the best things. So I think that's a very relevant thing that to consider, that to get over that emotional duress that we're having requires practice and having your team ready as well. So anyway, that's the third misconception. And the fourth misconception that I hear actually a lot is that I took BLS, I took CPR, I took ACLS or PALS. And I just find that you're just fooling yourself to think that's sufficient. In other words, not all emergencies require BLS or CPR or PALS. In fact, in my opinion, if you have to use that, that means things got too far along that you have to employ CPR. CPR, out of hospital CPR survival rates are like less than 10%. So you really don't want to use that as a skill set that you can depend on. There are things you can do before, in an emergency, before you would need to do ACLS or PALS or BLS, that can actually hopefully prevent you from even need to using it. And
Like what?
Well, say for example, someone has severe asthma attack. Someone has severe anaphylaxis, right? Someone severe a seizure, right? Like ACLS or BLS or PALS is not necessarily being used at that time for that, right? There's other things you can do. Let's take for example, someone who is having an anaphylactic reaction. Now that doesn't require CPR. That doesn't require mouth to mouth. You may need to bring out an ambu bag and maybe give them some oxygen, but there are other things you can do, and your team can help support you in that endeavor before CPR is even needed, maybe hopefully not at all. So to think that that is a skill set that's going to save you and save your practice and save that patient, while albeit important, is of course very misleading. And so for me, these four misconceptions, right? We won't panic. We'll know what to do. CPR is all we need, and a 911 will show up on time. Is all very misleading. And I think having that mindset feeds into this idea that feeds into the facts that patients could have a bad consequence under your care. I'll give you one stat. There was a report out of Texas about 7 to 8 years ago, and they found, when you extrapolate the numbers, when they were looking at bad outcomes in their state, they're having this rash of bad outcomes in their states, both deaths and near deaths, and they found that there's about two patients that die out of every 3 days in their state. All right. Let me rephrase that. There's 2 patients that die out of every 3 days in the United States.
I was like,
all right.
whew.
Yeah.
Like,
Sorry
whoa.
about that. On average. Okay. And the number of near misses is a factor of 5 to 7 times that number. So the people you never hear about, those close calls, the stuff that never makes the paper. All right. So when you talk to these malpractice insurance companies, turns out that number's higher. They don't reveal it, but behind closed door sessions, that number is about 1 person per day dies in this country due to a medical event that starts in a dental or oral surgery office. So that's about the equivalent of 2 LAX to JFK airplanes crashing and everyone perishing twice per year, letting that happen twice a year. And then that doesn't include the near misses. So it is an underreported situation. People are really suffering from this. You see all these bad reports, of course, in the lay press, but it's an under published, but yet a devastating impact on the patients and also your team and your practice.
Yeah, I'll tell you
So
what.
the
Oh, go
Oh
ahead,
no,
Pam.
I was going to say this statistic, is it due to anesthesiology? Is it due to medical emergency? Is it due to why are they dying?
So it's a great question. So what are the risk factors? The risk factors are typically sedation, if you're doing sedation in your office. Number two, extremes of age. So obviously the young versus the elderly. And then of course the people who are medically compromised. Those are typically the higher risk uh, groups for those statistics. Um, yes. Does that answer your question, Pamela?
Yes, thank you.
Yeah, I'm so, of course, Dr. Google is helping me out while we're talking. I'm still stuck on the whole 911 response time. The good news is if you live with me in Tampa, Florida, it's 5 minutes, maybe six. But the bad news is if you're back at home with me in Buffalo, New York, it's 9 minutes and 46 seconds. That's got to be the longest 10 minutes of anyone's life.
Yeah. And David, not only that, it's averages. It's averages. That's not that number and below. Um, and so it's a real, you have to know, here's the thing. You're not in your, most private practices, right? Most of your listeners, I assume, are private practice dentists. They're not affiliated with a hospital. Their clinic is not right next to a hospital. And so because of that, when there's a lot of assumptions that they have. And so when they're out there practicing on their own, especially if they're taking care of elderly or extremes of age, if they're taking care of someone that's medically compromised, uh, or if they're doing sedation, or God forbid, all three of those, that statistically there something could happen. And that's just, you're just playing the odds. For me, what is the risk, risk benefit, right? Is the benefit worth the risk? And that's what we have to weigh every day.
So you mentioned a checklist that offices must have in order for you to provide care in their practice. How many offices do you go into when you consult with them, have everything just ready to go?
Um,
Or would you say most of them need to add to their stock?
it depends what kind of office. So what I do when I go to an office, when they're a potentially new client, is I have to make sure that if they don't have the items, then I need to make sure we get it in advance, or either I or they get it. And I would say it depends on what office. So for example, so the three main clients I work with are pediatric dentists, oral surgeons, and endodontists. That's typically the typical dentists I work with. Um, most oral surgery offices have 99% of what I need to do sedation because they're used to getting sedation already in their office and such. Uh, most of the pediatric dental offices and endodontists I work with do not have the necessary items. Now, when I say necessary items, I mean not only the items that you would expect, like you would have in a health first emergency kit, but do you have other things like oxygen and an ambu bag and things that you would need whether I was there or not, right? So if a kid has a 5-year-old kid has a seizure in your office, do you have the tools to keep that child alive and safe until 911 arrives? And unfortunately, most general dentist office, endodontist, pediatric dental offices are not 100% prepared with the right tools and equipment for that. They have some basics, but not everything. Now, when you talk about sedation, that's a different way I approach things. That's a different level of equipment and supplies and medications and such. And most anesthesiologists should bring those items themselves. I do not personally believe the dentist should do that. They're not doing the sedation. Maybe that's something that can be negotiated for a dental office if they do bring in an anesthesiologist. Hey, I'll bring some of these things in, you bring this. But in general, the anesthesiologist should bring most of it. And I personally believe they should too, because they need to be familiar with the tools that they're bringing. the medications that they're supplying. They need to know what their option A, option B, option C is, what their contingency plans, what their redundancy situation is, or redundancy tools. And to assume that the office is going to provide that is, I think, a little bit cowboyish, like David alluded to before. The one thing unique thing about sedation in dentistry, it is kind of a Wild West. It is a Wild West. There's it's state to state variability in terms of requirements, and even on top of that, there's not much oversight. There's not much oversight in terms of making sure the office has all the necessary things. And then even then, when you look at the oversight, it's kind of a little soft, in my humble opinion. Like if you compare oversight in a medical hospital compared to an oversight that's in a dental office, it's just not the same. And so what it now becomes is you have to self-regulate. You have to self-manage and set your own standards, because I personally don't believe at a federal level or a state level is going to necessarily give you the best guidelines or guidance on preparing your team, for your office, for an emergency.
Yikes. So do you bring an assistant with you or somebody that's there to help monitor? Because I think a lot of times in dentistry, we just sort of like use our existing team and try to do it all at the same time.
Yeah, yeah. So I think, so to answer your question, yes, I bring someone along with me, all right? Most of the time. So let me kind of give you some background. So when you, and the reason is this: if we really care about safety, then what is that standard, right? If we just make our own standard, that could be, as we said, about the Wild West. You can make your standard as loose as you want. But if you really care about safety, there has to be some kind of standard. And so what's for me, the standard is, what are the top hospitals doing? What are the top, not the average hospital or your nearby community hospital, what are the top hospitals doing? And so when you look at them, the name brand institutions, they have layers of support. It's what Todd Conklin, he's a safety expert, and he advises like nuclear facilities, the military, and other major safety organizations in the world. He says, what you really want is you want capacity. The capacity means that you have not only the tools, but the team around you to support you during that event. So you look at a top tier hospital, they have that. Now, I'm not advocating that you need to have the hospitals of the resources of a hospital, but you have to have the principles of what a hospital is. So what do they have? They have people that know how to help manage an emergency, or you train your team to manage that emergency. So if you have an emergency in a code blue in your hospital, they have a team that's dedicated for that. Do you have that for your office? Do you have someone that, besides a dentist, that can support the dentist should an event happen, right? So, for example, do you have and so you have do you have people that are trained up and can work as a team, as a unit, and respond accordingly? The problem in dentistry is like all the training. I don't know if you guys noticed this. All the webinars and the in-person training that you guys get typically about medical emergencies, it is heavily consumption based. What I mean by that is, you go there, it's consumption based for the dentist. You go there as a dentist, you take this course, and you're like, oh, okay. You go through the 13 medical emergencies or so, whatever that number is nowadays, and you're like, oh, I feel so, I'm so energized. But then they just cannot leave you there. They just leave you there like, okay, now what? And what they don't do, and that's why people still leave, like, what am I doing for the rest of the day? Like, I'm not for the rest of the day, what do I do now? It's incomplete. It's so, I consumed it, but they don't give you the next step about application. And so people still leave feeling, I just had dentists tell me, I still worry I'm going to freeze in the dental office. I have an oral surgeon that tells me, I still think sedation is the most riskiest part of what I do. And then another pediatric dentist told me about a year ago or so, and she said, I I worry my team won't be able to support me. So even though there's all these resources out there for the dental world, it's still leaving a big gap. And so we have to look at what's out there. So when I come into an office, to answer, get your answer, Pamela, I kind of went off a little tangent. I'm sorry. I do bring support. Do I need it? Probably not. But I do recognize that if I do run into an emergency, and even though I trained the dental team to help support me over the years, to help work with me when an emergency happens, I still want another medical person around. So what I do, I personally, almost all my cases, I bring a paramedic with me. Now, why a paramedic? I mean, sorry, is this answering your question? Or maybe I should go to the next part.
No. Keep going.
Okay, thank you. So why a paramedic? So the paramedics I bring have to have at least 10 years of experience or more. I don't like rookies. I'm not a rookie. My people I work with are not rookies. I'm not going to subject a rookie paramedic to my patients. That's just my level of standard. And they have to be willing to work with me. Like, in other words, some paramedics don't want to, they just don't want to be, told what to do. So I vet my paramedics very carefully. And furthermore, a lot of them have pediatric experience. All right. So those are hard to find. That's just my standard. But the reason I chose paramedics is because they're very airway savvy, more so than your typical nurse. And so that's why, for me, I bring paramedics. I don't bring residents. I know some people bring residents. Again, I don't want to bring trainees. I'm in private practice. There's a certain level of care that I'm expecting, and I design it as if my own family is subjected to this kind of experience, as if my own kids were getting it. And I am not going to have people practicing with my kids in this environment. The window of opportunity to perform in a private practice when things are not going well is very small. And so you have to make sure that the people you have can perform quickly and effectively. You do not, if you look at it this way, if the hospital is like the Army, your dental practice should be like the Navy SEALs. It's specific for a very small skill set from a dental standpoint. And if you add sedation as an extra skill set, that's fine. But can the Navy SEALs, can your team perform at a high level by themselves until they have to get the resources of the Army to come help them, or otherwise known as 911? That's how I look at it. And so having capacity, having those resources when I do sedation is critical. Parents love it. The dentists I work with love it because they know that I'm bringing a level of safety that no one else that they know of is doing that, either in their city, state, or even maybe the country. But that's what I want, because that's what I would want for my own folks, my own parents, my own kids.
I love that. All right. So this is crazy as usual. Pam and I give each other this look every day when we're trying to figure out how 30 minutes goes by, because it does so fast. But super fast wrapping it up, because if I'm a dentist, what I need to know is like ballpark, because it's going to change city to city, but ballpark, like what kind of an investment should I prepare my patient for if I'm going to bring somebody from the outside in to deliver anesthesia, so I can make the math work in my head and maybe bring this to fruition in my practice.
Okay, so you're asking if an anesthesiologist comes into practice, how much that will cost the patient,
Yeah.
right? Okay.
Yeah.
Yeah.
So,
Range.
it can range it's highly variable.
Right.
So it can range anywhere from, $700-800 to as high as $4,500. And it depends.
Probably based on the amount of time that they're going to be with you.
But also depends on the dentist. So there are, if you talk about just pediatric cases, there are some offices that do sedation, and they do 5 sedations a day, 7 sedations a day. And the way they're able to do that is they're doing very quick procedures on kids, and they cut dry. And so these cases, the procedure time is literally 15 to 60 minutes. And so those cases turn over faster. And obviously the work is not as much as maybe a longer case. The cases I get involved in, they're longer. The dental time is anywhere from an hour and a half to 3.5 hours. Sometimes full mouth rehab, sometimes just kids who need a lot of extra work. And we use water. So a lot of times for the pediatric dental cases will intubate. And so therefore it takes a little bit more time, a little bit more invasiveness, a little bit more medications, and therefore, of course, the cost is a little bit higher for the parents. So it depends on your area. For example, I used to do sedations for pediatric dental offices in Cincinnati area. Those dental offices, a lot of them like to cut dry, and they'll do these fast turnover cases. In the Northeast, in the United States, the pediatric dentists love their water. And so those cases will be a little bit longer and a little bit higher investment.
Makes sense. Thank you. That's helpful.
Yeah.
Interesting. So how do people find you if they want to learn from you, if they have questions, etc.?
Well, they can basically check out my website. We're going to launch it pretty soon. It's drrichardmarn.com, drrichardmarn.com. Or check out one of my clinical website, which is New York Medical Anesthesia or Blue Pacific Medical Simulation. Blue Pacific Medical Simulation is a risk management or risk reduction company. We help improve your team alignment for medical emergencies and sedation emergencies. So that's the best way. But I think the best way, obviously, the simplest thing to do, follow me on LinkedIn. I'm easy to find. I'm the only Richard Marn out there as far as I know. And you can follow me. I post a couple times a week. And it's almost always about sedation related or medical related emergencies.
Fantastic. Guys, thanks for being here this week. Richard, thank you for everything you brought to us today. I'm a big fan. I like doing things once the right way and not having the risks and all it takes is one time. So if you're out there and you're doing sedation, I hope you maybe kind of thinking if you're doing things the best way. And if you're looking into sedation, hopefully this gives you some tips and direction on where to go. So thanks for being here, everybody.
Thank you.
Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela _Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.